Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thank you, Brian. Welcome, everybody. Brian asked me to talk about Mycobacterium Avium complex because we have had some cases, I think, in our echo community recently, and thought it might be good just to review some basics about MAC and its treatment. When I started to look into this, I was surprised at how little there is published on MAC and HIV in the last decade. So much of what I'll review here will be probably a review for everybody, but I will talk about some older papers that it's probably worth looking at again because they might impact the way that we treat people, at least initially. So this is my one sin last year. I adjudicated some cases for Merck and the development of a new assay. And this is a reminder that HRSA, through a grant that David Spock has acquired, supports Project Echo. So grateful to them for that. And then a reminder that any data presented offers only a limited perspective of how systemic, social, and economic factors impact health. And we should all remember that racism, not race, perpetuates and creates health disparities. We'll start with a case presentation. This is an actual case. A 23-year-old patient of mine many years ago, not previously diagnosed with HIV, presented with anorexia, dysphagia, profound weight loss over 6 months, night sweats, fatigue, and diarrhea. On initial examination, he was cachectic and apathetic, had a low-grade temperature, soft blood pressure. He was tachycardic to 110. And on physical exam, had obvious thrush, seborrheic dermatitis, indurated purple plaques that were KS on his face, feet, and hard palate. And his liver edge was below his right costal margin by a couple of finger breadths. He tested positive for HIV. His CD4 count was dramatically low at 14, and a plasma RNA level came back at almost 500,000. So he declined hospitalization from his presentation to the ED, but was in receipt of a couple of liters of fluid. He was given fluconazole for thrush, started on trimethoprim sulfamethoxazole, as well as azithromycin, and elected to go home. He did fortunately return to clinic 2 weeks later without thrush or dysphagia. He claimed to be taking his Bactrim and his azithro, but his diarrhea, fevers, and sweats had not abated, and he now complained of abdominal fullness and abdominal pain. So what conditions might explain his symptoms of diarrhea, fever, sweats, and abdominal pain? And I think things that were under consideration were lymphoma. We knew he had cutaneous KS, so might he have visceral KS as well? Intestinal infections with some parasites, as well as some cytomegalovirus, since cytomegalovirus often is associated with pain. Disseminated mycobacterial infections like TB, MAC, M. bovis, or other NTMs, or disseminated fungal infections. Histoplasmosis would make the list there. And diagnostic studies that I'm sure all of you would want to get right out of the gate include some chemistries and CBC. His LDH was mildly elevated. His hematocrit was quite low. He had mild transaminitis, but a remarkably elevated alkaline phosphatase and a big protein gap. His stool EPP, or enteric pathogen panel, was negative, and ONP was negative. And blood cultures for bacteria, mycobacteria, and fungi at the time were negative or pending. Urine histoantigen also negative, and immunologic testing for previous exposure to TB, both negative. So what next? After that, those chemistries and laboratory values and physical exam, we might want to scan him to see what was going on in his abdomen. That was done. Large adenopathy throughout his mesenteric distribution throughout his abdomen. And what next? The diagnosis remained Elusive, what I'll show you next is not his, but is representative of what would have been found had he had a liver biopsy, and that is a specimen that was chock full of acid-fast bacilli and no granulomas. Didn't really have the immunologic health needed to form a granuloma, so had overwhelming mycobacterial infection, lots of organisms, but not much of an immune response to them. So he ended up growing Mycobacterium avium complex. And just a few words about that organism. Formerly called Mycobacterium avium intracellulare, now Mycobacterium avium has a couple of subspecies, Hominisuus and Columbiense. Other NTMs like Genevense, Kansasii, Simii, and Mycogenicum were probably included in old studies of MAC, but they just hadn't really speciated the organism very carefully back in those days. And so they were probably included in patients that were just generically thought to have had disseminated Mycobacterium avium. It is a ubiquitous organism found throughout the world in soil and water. It was a very common opportunistic infection in the pre-ART era, with an incidence rate, depending upon the paper you looked at, between 20 and 40%. Now, less than 2 cases per 1,000 person years, including people that are not started on ART. So for whatever reason, perhaps prophylaxis in those people that are not on ART, or certainly the effect of ART is responsible for that change in incident rate. Infection is initiated either by inhaling the organism or by ingesting it. It's not reactivation. These graphs are from a paper that's 20 years old now, but just looked at the effect of antiretroviral therapy, showing both less disease in the panel on the left and then better survival in the panel on the right. Again, this is an old paper, and I think that the blue line on the panel on the right would start to curve upward because probability of living is much, much better than it was back when even before this paper was published. So its clinical presentation, I think all of us know fairly well. Disease happens typically in people whose T cells are less than 100, in fact, a median of around 60. Those who present with disseminated disease are just like the patient I presented: fever, sweats, weight loss, abdominal discomfort, anemia, organomegaly, usually hepatomegaly, and basilemia. Those with localized disease can present with just diarrhea or cholangiopathy if it invades the ampulla or up the common bile duct, adenitis, endobronchial lesions, pneumonia, even cutaneous lesions. But localized disease is typically occurs in people with higher CD4 counts and more often after people have been put on antiretroviral therapy. The diagnosis is typically for disseminated disease made by positive blood cultures that trip positive in over 90% of cases. Or if you're impatient, you can go after tissues like bone marrow or liver and see the organisms histopathologically and perhaps make a diagnosis sooner than waiting for blood cultures. It's good to note that only 2/3 of those that have MAC cultured from the GI or respiratory tracts will actually develop basilemia. So not a reliable marker for disseminated disease. Prophylaxis was recommended when T cells were less than 50, but it was old recommendation to hold that if the patient might have cryptic infection or you're going to be starting antiretroviral therapy. Prophylaxis is with a macrolide, typically azithromycin or clarithromycin. Rifabutin was listed if the patient was intolerant of a macrolide, but you don't want to use rifabutin if there's any possibility the patient might have occult tuberculosis. And discontinuing prophylaxis was recommended when T cells were over 100 for 3 months. Recommendations from the IAS USA guideline 8 years ago said primary prophylaxis is not recommended in those individuals if effective ART is initiated immediately and viral suppression achieved. And then more recently in the DHHS guidelines, Again, prophylaxis not recommended unless people will not be starting ART, or those who start ART but remain viremic, then prophylaxis is indicated. So, preferred treatment. First, you've made the diagnosis, you have the organism growing, you must test for macrolide resistance because they are the cornerstone of therapy for MAC infection. And it's either clarithromycin, 500 milligrams twice a day, plus ethambutol, or azithromycin, 500 to 600 milligrams a day, plus ethambutol. And this is worth emphasizing. Rifabutin you can consider adding in patients with severe disease, but it is not a requirement right out of the gate. And if the patient has very high viral load, if you're worried about drug resistance, let's say that they were on azithromycin as prophylaxis but broke through, or certainly if they're not going to be started on ART, then you can consider adding a fourth drug, either a quinolone or bedaquiline, linezolid, or omadacycline combination therapy is worth considering. Duration of treatment is a year, but you can shorten that for people who do get started on antiretroviral therapy and who have a brisk reconstitution of their immune systems. Whatever, though, you probably should keep people on therapy until CD4 counts are greater than 100 for 6 months. So first question might be, which macrolide? Should it be clarithromycin or azithromycin? So now we have to go back to some old studies that were done, published in the late 90s and early 2000, but were actually performed in the pre or spanning ART era. So this first study was performed in 1991 to 94, so the pre-HART era, and compared clary plus ethambutol to azithro plus ethambutol. And the outcome was clearance of bacteremia out to 16 weeks. And you can see on the panel on the right that the black bars represent clarithromycin, and there was a dramatically different clearance rate, improved clearance rate, nearly 100% on those patients who were randomized to clarithromycin instead of azithromycin. This is another paper. Again, this one was conducted 1994 to 1998, so some pre-ART and post-ART era, throughout the Americas as well as the Netherlands, and once again compared clarithromycin plus ethambutol to azithromycin, 2 different doses, plus ethambutol. Only about a tenth of the 246 patients were on highly active antiretroviral therapy, and at the time, the only other choice to make it highly active was a protease inhibitor. And there was no difference in the clearance of bacteremia, which is the upper panel on the right, and no difference in survival, which is the lower panel on the right. Relapse rate was a little higher with azithromycin than clary, but that did not reach statistical significance. And then this paper published, I don't have a date about when this was done, but this was a smaller study. I included it because it showed one important fact to remember: randomized study of 85 patients with disseminated MAC and HIV, 2 doses of clarithromycin, 1,000 milligrams twice a day or 500 milligrams twice a day, plus ethambutol, plus either clofazimine or rifabutin, so a 3-drug regimen. And the important point from this paper was that those who were randomized to clarithromycin at the higher dose, 1,000 milligrams twice a day, had a higher death rate, a significantly higher death rate than those who were randomized to the lower dose of 500 twice a day. And suggested explanations for this include that high concentrations of clarithromycin are associated with inhibition of T-cell proliferation, so further impairing T-cell mediated immunity. And also in vivo, it does suppress levels of IL-6 and other cytokines. So if you choose to use a clarithromycin over azithromycin, just remember the dose cannot be a gram twice a day. And then finally, clarithromycin has some other problems. There's more side effects with clarithromycin, more GI toxicity, more rash, and also it is a very potent inhibitor of both P450 3A4, and P-glycoprotein. So there's lots of drug interactions that you have to fret about. And I just listed common ones here, or ones with drugs that might be used in HIV patients, the rifamycins, protease inhibitors, non-nucleoside reverse transcriptase inhibitors, and even CoV-boosted elvitegravir. There are all consequences of using those drugs with clarithromycin, and the recommendations are either to use with caution, to not use it at all, and consider alternatives to Clary. So it just makes it a little bit more complicated. So second question, after you've decided to treat somebody with either clarithromycin or azithromycin plus ethambutol, does adding rifabutin help? So this study, again, older, prospective randomized placebo-controlled study of 200 patients conducted 93 to 96. So just up until the time that we had good antiretroviral therapy. Patients were randomized to clarithromycin plus ethambutol and then either rifabutin or a placebo. And at 16 weeks, there was no difference in bacteriologic response with either one, and the rates are shown there, 61% clearance versus 63 if you added rifabutin. And similarly, there was no difference in clinical responses or survival of any of those patients. Contrast that with this study that was published by Connie Benson. Again, this was in the peri-ART era, so only about 15% of the patients in this study were on a regimen that was designated highly active, and at the time that meant including a protease inhibitor. So this was a prospective study as well of 160 patients with HIV and DMAC who were randomized to Clary plus ethambutol, Clary plus rifampin, or all three. The relapse rate was highest for the group that got clarithromycin plus rifampin, 23%, compared to 6 and 7% in the other two arms that had ethambutol in. The death rate, however, was lower in the people that got all three drugs, the hazard ratio being 0.44 to 0.49 for the group that got clarithromycin plus ethambutol plus rifabutin. And when they adjusted for protease inhibitor use, the hazard ratios were less prominent, but still it was less likely you would die if you got all three compared to either of the other two regimens. But remember, again, only about 15% of patients in this study were on highly active antiretroviral therapy. The panel on the right shows the Kaplan-Meier curves showing that the three-drug regimen led to better survival. This paper got a lot of followers back then. So my treatment conclusions are to treat disseminated MAC with a macrolide and ethambutol. Clarithromycin is more active against MAC than azithromycin and clears bacteremia faster, but it probably does not enhance survival and is associated with more adverse effects and more drug interactions that you have to deal with. Furthermore, clarithromycin at higher doses is associated with worse outcomes, higher death rates. The addition of rifabutin to a macrolide and ethambutol enhances survival in those who are principally not on antiretroviral therapy, but is probably of little value in those that are already on antiretroviral, highly active antiretroviral treatment. Exceptions to that might be in those patients who have severe disease, who have very high levels of mycobacteremia, or on whom you're worried about macrolide drug resistance. In those cases, then adding a third drug or sometimes a fourth drug might be helpful. Other considerations, those not responding to treatment should have repeat blood cultures drawn 1 to 2 months into treatment. Treatment of those who do relapse should be with a new regimen containing at least 2 new drugs to which the organism is susceptible. So that might include a quinolone or linezolid or bedaquiline as you put together your new regimen. And if your patient does have a macrolide resistant organism, then there's no point in continuing the macrolide, so stop it. And then finally, clarithromycin should be avoided in women who are pregnant. This recommendation is based on animal studies. Then very quickly, just back to the case. Our patient was started on azithromycin and ethambutol, and he gradually got better over the next few weeks, but then started on antiretroviral therapy, dolutegravir anchored regimen, and 3 weeks later presented with recurrent fever, abdominal pain, and a left-sided abdominal mass. You might remember this was his original CT scan showing a lot of mesenteric adenopathy, and this is weeks into ART. That adenopathy is now necrotizing and liquefying. So this was clearly a case of MAC iris, and the clinical presentation, as I'm sure you all know, fevers, sweats, swollen lymph nodes that can be anywhere. In those whose counts are still low, more severe illness, fevers, weight loss, leukocytosis, maybe even persistently positive cultures. Those who have a robust CD4 response will often have more localized and suppurative disease, maybe just cervical adenitis or something, and fewer systemic symptoms. And the treatment for patients who present this way are to forge ahead with antiretroviral therapy, continue their MAC therapy. For those that have mild symptoms, NSAIDs, and for those that are really affected by it greatly, then prednisone at about 0.5 mg per kg per day.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.